Xin chào tất cả các bạn. Theo Global Can năm 2020, ung thư cổ tử cung là loại ung thư phổ biến thứ tư ở nữ giới sau ung thư vú, đại trực tràng và ung thư phổi, là nguyên nhân gây tử vong đứng hàng thứ ba. Trên 99% ung thư cổ tử cung là do virus HPV gây ra. Ung thư cổ tử cung là loại ung thư hoàn toàn có thể tầm soát và phòng ngừa một cách hiệu quả. Hôm nay chúng ta sẽ được bác sĩ Golden Menendez đến từ trường y khoa Yale trình bày về cập nhật các tầm soát ung thư cổ tử cung. Cô sẽ trình bày dựa trên các cập nhật tầm soát ung thư cổ tử cung từ Hiệp hội Ung thư Hoa Kỳ ICS và lực lượng đặc nhiệm dịch vụ dự phòng của Hoa Kỳ, viết tắt là USPSTF. Hy vọng qua bài trình bày này chúng ta sẽ nắm được phân nhóm nguy cơ trong tầm soát, các phương tiện dùng để tầm soát, khi nào chúng ta bắt đầu tầm soát và khi nào chúng ta có thể ngừng tầm soát, cũng như xử trí những trường hợp bất thường trong quá trình tầm soát ung thư cổ tử cung. Vâng, chúng ta cùng bắt đầu nhé.
Okay, so the talk tonight is going to be essentially about the epidemiology of cervical cancer, followed by risk factors and the significant role of HPV or human papilloma virus in causing cervical cancer, as well as the significant impact of screening guidelines and guidelines based on age and risk group stratification. So in 2020, cervical cancer accounted for an estimated over 600,000 new cases and over 300,000 deaths worldwide. And not surprisingly, over 85% of cervical cancer cases, they were from resource-limited countries. Cervical cancer was the second most common type of cancer and the third most common cause of cancer mortality. When we look at the continents of Africa and Central America here, we can see the cervical cancer was the leading cause of cancer-related mortality among women. Here we can see in the US, we have over 13,000 new cases with over 4,000 deaths that we see every year. And this is what we do not want to see as providers. This is a huge mass arising from the cervix here, as well as right here. We don't want to see these cases in the next couple decades, hopefully. As far as the risk factors that lead to cervical cancer is concerned, we have behavioral and sexual factors, including large number of sexual partners one might have and early age at first intercourse. Also, smoking has been linked to increase the risk of specifically the squamous kind of cervical cancer, not necessarily the second most common kind, adenocarcinoma. We have history of sexually transmitted diseases, and in communities with a diet low in folate, carotene, and vitamin C, we tend to see more numbers. Among other risk factors, again, comes multiparity and early age at first intercourse. These all increase the likelihood of HPV exposure, and a lack of routine screening is the one that we're going to emphasize tonight. Immunosuppression is another risk factor for developing cervical cancer, and infection and exposure to HPV is vital. HPV also known as human papilloma virus, is central to the development of cervical neoplasia or precancer, and it can be detected in over 99% of cervical cancers. 80% of the population are exposed to this virus by age 50, and among more than 40 different genital HPV types identified, we have about 15 known to be oncogenic. It's a double-stranded DNA virus, and it infects the epithelial cells in the skin and mucous membranes of vagina and cervix. The oncogenic HPV infection of this transformation zone, here we can see the columnar epithelium of the cervix bordering on the squamous epithelium. This is known as transformation zone, is where the HPV virus starts the infection. And then that would lead to precancerous changes and eventually to cancer if there is no screening and no treatments. Here we can see at a more cellular level the changes that HPV causes, including the coilocytic cells here, the halo around the nuclei of the cells, as well as the binucleation. Our objectives with screening is essentially to prevent morbidity and mortality from cervical cancer, as well as preventing overzealous management of the precursor lesions that will likely regress or disappear when a patient has a competent immune system. The United States adopted pap smear screening in about 1950s, and by mid-1980s, cervical cancer incidence decreased by about 70%. Multiple observational studies continue to show the reduction in cervical cancer mortality after systematic follow-up and screening guidelines. What do we screen in day-to-day life? When we see a patient, we place a speculum in the vagina, and our goal is to inspect the entire vaginal mucosa, as well as the ectocervix and the endocervix. Here we can see a close-up image of the upper vagina, cervico-vaginal junction, which is important for cervical cancer screening purposes, the ectocervix, and the endocervix, which is the glandular epithelium. So both the endocervix and the ectocervix is important for practical reasons in terms of screening. In the United States, approximately 50 million women undergo a pap smear or HPV testing each year. And of these women, about 8% will have an abnormal result. And here, this pyramid shows us the breakdown of pap test abnormalities by frequency. Screening can detect the precursor as well as the early stage for cervical cancer. That way, we can prevent the development of invasive cervical cancer. When a patient is exposed to HPV, the healthy young woman would likely get rid of HPV in about 6 to 12 months. Sometimes when we cannot eliminate the HPV exposure and it persists, we have low-grade cervical precancer changes known as CIN1. In about 24 months, again, a healthy immune system will clear the HPV. If the patient has risk factors as well as not a competent immune system, the low-grade lesions might turn into CIN2 or 3, which is known as high-grade precancer changes. And if there is no intervention, in about 10 to 13 years, the high-grade precancer cells will turn into invasive cervical cancer. So it is not a change from HPV exposure to cancer that occurs overnight, which gives us the opportunity as providers to intervene and eliminate cervical cancers. What happens when a patient has an abnormal screening test? One of many things can happen. The patient might need further testing with HPV. The patient might need a repeat cytology, colposcopy, or even endometrial biopsy if the cytologic abnormality arises from the endocervix, which is the glandular epithelium, which is very much like the endometrium, and that would require evaluation as well. Or some patients would be referred to GYN oncologists when there is high-grade precancer changes. The way that we perform colposcopy is in the clinic. There is a microscope that is essentially helping the provider to magnify the image in the vagina and the upper cervix. And if need be, colposcopy-directed biopsies can be taken for biopsy purposes. If the patient has any high-grade precancer changes, oftentimes we recommend patient to undergo conization, which is simply a cone-shaped biopsy of the cervix to eliminate underlying invasive cancers. The way that we perform conization is usually with a cold knife. This kind of illustrates how those procedures are done. Another way of getting a larger biopsy than just a small cervical biopsy to eliminate underlying cervical cancer is LEEP, which stands for Loop Electrosurgical Excision Procedure. This is mostly used by primary OBGYNs, and it can easily be performed in the office setting. So how do we get patients have cervical cancer in 2022? It has to be one of many failures that lead to it. Either the patient does not show up for screening, or as healthcare providers, we do not offer screening to women when they present for annual exams. The patient might not follow up on abnormal results when there is a colposcopy and a biopsy that shows precancer cells. or the patient might not get appropriate treatment to eliminate the precancer cells, and eventually, unfortunately, the patients get cervical cancer, which is our ultimate goal with screening to prevent this. So tonight we're going to mainly focus on these updated guidelines, which originate from American Cancer Society 2020 update and USPSTF, which stands for United States Preventive Services Task Force, which was most recently updated in 2018. For purposes of screening, we should define what an average versus a high-risk patient is for developing cervical cancer. An average patient for us would be who is asymptomatic with a competent immune system and who has always had normal screening results in the past. And most of the guidelines focus on average risk patients, since this is what we most commonly handle. High-risk patients would be the ones who have immunosuppression for any reason, who has HIV, or who has been exposed to DES in utero. DES used to be an antiemetic that was used in pregnancy until 1970s. So most of these women are now in their 50s, 60s, and it's not used anymore, thankfully. So there is one less risk factor these days as far as cervical cancer screening risk stratification is concerned. So the 2018 USPSTF essentially recommends that cervical cancer screening should begin at age 21 and no earlier than 21, regardless of the age of sexual onset. And the main reason for this is the main concern that would be associated with adverse outcomes with follow-up of young reproductive age women when they have minor cytologic abnormalities. The risk in less than 21 years of age is about 0.1% for cervical cancer. For that reason, most guidelines, including USPSTF, do not recommend starting cervical cancer screening prior to age 21. As far as ages 21 to 29 group is concerned, we have one of two ways of screening these young women. USPSTF recommends cytology alone every 3 years. On the other hand, the most recent 2020 guidelines from American Cancer Society prefers HPV testing alone, starting age 25 as opposed to 21, and doing this screening every 5 years. The important thing about HPV testing is, one, it's not available in all institutions in the US or in many parts of the world, and it can only be performed with the 2 FDA-approved primary HPV testing methods, including the one from Cobas and OnClarity. So its use is a bit limited at the time being in the US. There are countries like Australia and Netherlands and UK, which has these tests readily available, and they have been employing HPV testing as their preferred strategy. The rationale for USPSTF recommending age 21 to initiate cervical screening is, again, the very low incidence of cervical cancer being 0.1%. And they favor cytology or pap smear over HPV testing because of the higher rates of transient HPV infection. The thought process is that if we do HPV testing in young women, they are more likely to test positive, and we are going to put them through unnecessary colposcopies, cervical biopsies, and conization biopsies that would then impair their obstetric outcomes. And these guidelines from USPSTF, they don't account for HPV vaccination rate. So that's one of the shortcomings of these guidelines. When we look at American Cancer Society recommending age of onset for screening 25 is, they cite 0.8% cervical cancer rate prior to age 25, and it was deemed not to be cost effective to screen women prior to age 25 for that reason. However, they do prefer primary HPV testing due to higher specificity. And the one plus from these guidelines over USPSTF is that they account for HPV vaccination rates. When we look at the age group 30 to 64, 65, this is going to be a big pool of patients. And we have 3 options here. we can either do co-testing, which is known as combination of cytology or pap smear plus HPV test. And this can be done every 5 years and not any more frequent than that. The second option would be primary HPV testing every 5 years, or cytology alone, pap smear alone every 3 years. So one of these three would be reasonable as far as both of these guidelines are concerned. The USPSTF does not prefer one over the other. However, American Cancer Society favors primary HPV testing every 5 years for women aged 30 to 64. How about women over age 65? Essentially, this age group, we will decide to discontinue or continue screening based on the patient's prior results, life expectancy, and shared decision-making. If the patients never have had any CIN2 or high-grade cervical precancer lesions, and they have adequate negative screening, which is defined as 3 consecutive negative PAPs, or 2 consecutive negative primary HPV testing, or 2 consecutive negative co-tests within the last 10 years. This is defined as adequate negative prior screening. These women can preferably discontinue cervical cancer screening. In many European countries, they do continue until age 75, considering the improved life expectancy in the last couple of decades. And most guidelines do not study this particular question. So I do a shared decision-making with the patients when it comes to stopping cervical cancer screening. 65 is not a hard stop. If the patients had a total hysterectomy, meaning their cervix and uterus had been removed and they never have had any high-grade cervical precancer cells, we can stop screening even though the patient might be younger than 65. Most women who need hysterectomies, they do need it for abnormal uterine bleeding, which is something they struggle with prior to age 50. So if we have a patient age 45 who is done with childbearing and underwent a hysterectomy with removal of their cervix and uterus, and they never have had any CIN2 or high-grade precancers in the past, that patient can stop screening for cervical cancer. When is not appropriate to stop at age 65, if a patient has had these high-grade precancer cells, namely CIN2, 3, or adenocarcinoma in situ, then routine screening should continue for an additional 20 years from the last high-grade precancer lesion, and that might well extend beyond age 65. These all, everything we talk so far essentially relates to average risk patients. When it comes to high-risk patients, we talk about patients with HIV, patients who have been exposed to deaths in utero or have immunosuppression for any reason. For those patients, the guidelines are a little bit more strict, and the recommendations are to do cytology or pap smear every 3 years, annually, 3 years in a row. And if the results are normal, then we can space the screening out to every 3 years. If we decide to do co-testing, meaning we do a pap smear along with HPV testing as the baseline, and both cytology and HPV result came back as negative, then we can go ahead and screen these women every 3 years moving forward. We do not stop at age 65, given the higher risk of HPV persistent and higher risk of high-grade precancer lesions in these women. We continue throughout lifetime, and we do have a much lower threshold to do colposcopies and biopsies. When we look at future directions, one thing to consider is going to be the impact of HPV vaccination. As the proportion of vaccinated individuals increases, the prevalence of high-risk HPV types is expected to decrease, and that will eventually reduce the positive predictive value for both cytology, pap smear, and primary HPV testing. So we have some ongoing randomized controlled trials to evaluate the performance of primary HPV testing versus cytology in HPV vaccinated women. The second thing to consider moving forward in the next decade is going to be probably we will see a diminishing role of cytology and uptake in primary HPV testing. as the countries such as Australia and Netherlands that has the lowest rate of cervical cancer have been employing for over 10 years. The other possible practical solution to improving the uptake in screening is self-sampling. Essentially, patients will start sampling themselves in any setting and mail these to the providers for evaluation. However, at the time being, this is not an FDA-approved strategy, so I am hoping that it will be enabling providers to improve the uptake in screening once FDA approves self-sampling. Summary of guidelines. Essentially, 2012 was the previous American Cancer Society guidelines before the 2020. And the age of onset for screening then was 21, and age to stop screening was 65 with pap test every 3 years. As we look at the most recent guidelines, we talked about 2018 USPSTF and 2020 American Cancer Society. There is not much changes to USPSTF guidelines, which says we should start at age 21 and stop screening for cervical cancer at age 65. And for women less than 30 years of age, pap smear is preferred over HPV testing since there is such high prevalence of HPV exposure in the younger patients, and that is most likely to resolve and persist. And over age 30, we can use one of three methods, namely pap test every 3 years, primary HPV testing every 5 years, or co-testing that combines the pap with the HPV every 5 years. When we look at American Cancer Society, it's a little easier to remember, and I think this is going to be kind of more prevalent moving forward once we continue to understand the importance of HPV in causing all these precancerous and cancerous changes. And the age to start screening for American Cancer Society is 25. They recommend stopping at age 65, and primary HPV testing every 5 years is what is preferred. So cervical cancer is one kind of women cancer that we can definitely prevent now that we know that over 99.7% of these cases are caused by the HPV virus. So as we increase the awareness and increase the uptake of screening and HPV vaccination, as GYN oncologists, we hope to eliminate this cancer in the next decade or two. And this is all I have. I'll see if I have any time for questions.
Vâng, bài học đến đây đã kết thúc. Cảm ơn các bạn đã chú ý lắng nghe. Nhớ like, share và subscribe để theo dõi các bài học tiếp theo. Xin chào và hẹn gặp lại.